Hi, Kevin Henry, the Group Editorial Director for UBM Medica's Dental Division, and I'm on a Google Hangout today with Dr. Dan Indech. Dr. Indech, would you take just a moment to introduce yourself and tell us a little bit about your practice, please?
Daniel Indech. I'm a periodontist in Phoenix, Arizona. I've been practicing here for 15 years. I did my training in Canada back in the late 80s, early 90s. Graduated from University of Western Ontario with my DDS, and then did my specialty training at University of British Columbia in Vancouver. I'm in private practice. I have my own clinic, and I also participate with other larger dental groups doing an on-site specialty care practice.
Sounds great. Well, I really appreciate you taking a few minutes to chat with us today. And I know the focus that we wanted to talk about today was 3D imaging. And I know it's something that you've incorporated into your practice. And I was just wondering if you could just kind of give us, just to start, a basic overview of how 3D helps your practice and helps you as a practitioner.
Over the years, I have used the 3D imaging, but I found myself always referring patients out to scan centers for me to get that information. I would get either a disc or I'd get a DICOM file. Really wasn't able to manipulate the data as well as I would have liked to, but having that information allowed me to make critical decisions regarding jaw anatomy, primarily in my implant dentistry practice. It's allowed me to make diagnosis on conditions that I couldn't arrive at a diagnosis with 2D imaging or clinical examination. Recently, I installed a 3D scanning machine, and it's taken me to the next level with regards to having the data, being able to manipulate the data in a manner that allows me to eventually see what I'm looking for, or see what I need to see.
Obviously that's a bit of an investment to get into 3D imaging. And how did you know that was right for you? And then what kind of ROI do you look at to know that it's right for your practice?
I look at it in two ways. In a more narrow manner, I want to know that I'm utilizing that piece of equipment sufficiently to cover the investment that I made. But on a broader basis, I look at where we're going and where we're at with standard of care, and the value to me of having that information, both from a diagnostic standpoint and from a protective standpoint. You really can't put a price on it or a number on it. So, and what I found in the short amount of time that I've had my own machine is that there's cases that I previously thought that I couldn't do, that once I got the data and analyzed it, I decided I could do them. Which has increased the number of cases that get into my schedule. And on the other hand, there's cases that I had looked at, or that I may have looked at with other forms of data, 2D panoramics or PAs, and I may have opted to do them. And once I've evaluated the scan information, I've decided either not to do them due to risk, or to treat them differently. For example, cases with insufficient bone require bone augmentation procedures leading into eventual implant placement procedures. So, on one hand, it's allowing me to do cases that I previously thought I couldn't do, and there's an obvious increase to the bottom line with that, but it's also allowing me to keep myself safe and out of trouble, by managing cases that are either difficult, borderline, or not doable, managing them properly and not getting myself into a difficult situation.
Have you had any good hidden surprises about having 3D imaging in your practice? Things that you didn't even expect to be able to do in your practice that now you're able to do because of that?
I have a couple of interesting stories arising from taking a scan prior to a procedure where in the past we really didn't reach for a scan, or we went with conventional panoramics or periapicals. The one case that comes to mind is a younger patient, a teenage patient that was referred to me for an exposure of an impacted canine tooth. And, typically we'll go off of PAs or panoramics, and 9 times out of 10, the cusp of the tooth is somewhere in the palate area. And we open the palatal tissue and we find the tooth, and we expose the crown, and we attach a bracket, bring the chain out of the gum, and then the orthodontist can pull the tooth into the mouth. So in this particular case, I took the 3D image, and I could see from the image, and I couldn't see this from the panoramic that the orthodontist sent me, I could see that the tooth was actually erupted on the facial side. And in the past, I would have approached that from the palatal side. I wouldn't have found the tooth, and then I would have had to open the facial side, and eventually got the procedure done. And this way I went straight to the facial side, found the tooth, attached the bracket, and it ended up being a much less traumatic surgery for the patient. And going forward for exposures of impacted canines, I won't do one without a CT scan, just because of the possibility that the tooth may be somewhere where we don't expect it. Another example is in a patient that I treated maybe 6 months ago, 5-6 months ago. I was placing 2 implants in the upper right back quadrant, sites 3 and 4, and I had previously done a sinus lift. She had tooth number 2, and it didn't seem to be problematic in any way. Prior to the surgery, we did a 3D, and just as a coincidence, looking at the root of 2, I found a fracture in the root that I did not see clinically, and I did not see on periapical radiology that I'd previously taken. The implants were placed, and the tooth was extracted at the same time, and it was very easy for me to show the patient why I needed to extract this tooth. Had I not seen that, potentially the implant at site 3 may have been threatened by this tooth that developed root canal infection, and it could have become very problematic for us. And I just were no symptoms, but it showed up so clearly on the 3D scan that it was obvious to me, and the patient had no issue understanding the condition and then allowing me to do things that they needed to be done. So there was a good measure of fortune, but also protection for the patient there.
It's amazing. Can you just tell me what's the one thing that if one of your colleagues doesn't have 3D imaging in the practice, what's one thing you would say to them to maybe encourage them to take a look at it?
I find, and I would share this with anybody, that the initial expectation for the use of that technology for me was specifically for implant diagnosis and implant surgery. And now I'm finding that it reaches far beyond that. I have implemented it with wisdom teeth extraction, for example, and we see where the wisdom teeth are on a panoramic x-ray, but on the 3D you can see the root anatomy and the curvature and the exact location, and from that information you can much more readily predict how that tooth is best removed, and so it enables more efficient treatment, less challenge, less root fracture, for example, a root tip fracture. It allows me to plan the extraction better, and I didn't expect that I would become reliant on, on a 3D image for wisdom teeth extraction or for just for teeth extraction in general. Endodontic diagnosis is a big area where we're seeing things that we could never see before, and things that conditions that are challenging to diagnose, vertical fractures, perforation defects, lesions in bone. It's hard to see where exactly they are. Now we can see them very clearly and come up with a tighter treatment recommendation for those endodontically challenged. And that's a big area that I think will continue to grow. And there's a big value for the periodontist because often those teeth that have struggled with endo treatment or endo conditions, chronic pain, non-healing infections, at some point the endodontist gives up and refers the patient to the periodontist, and we're asked to deal with it. It's easy to deal with those teeth by extracting them, but there's a big value in having data and having a visual record of what was actually wrong with that tooth should it come the full circle at a later date. Protection for endodontists, for myself, and I think that's really key, and that will grow. So in the area of diagnosis, there's endless opportunity, and it amazes me the number of, particularly in that endo area, the number of teeth that I see where there's a diagnosis that was made by someone else, and having reviewed the data, the diagnosis is not correct. And I don't point fingers at anybody, but those are the ones that would benefit from having that type of technology because they can make a more accurate diagnosis. So in the area of endo, eventually, I believe that any tooth that becomes challenged, they're struggling with this tooth, and they'll see more than not what's actually wrong with this tooth. Oral surgery, perio, endo, implantology. I'm even using it in my perio diagnosis to assess the bone anatomy in order to make decisions on surgical treatment, regenerative possibilities that are borderline, where instead of waiting for a intraoperative decision, I'll try to make a preoperative decision, and I can do that better with images.
Dr. Indech, I really appreciate your time. It's been a great time of learning for me just to hear about how you're doing things in your practice. I really do appreciate that.
It's my pleasure, and I think this technology is game changing for any of the disciplines that that get underneath the gum line, deal with conditions on the inners, do surgery, anything from exodontia to endodontic surgery. I've had multiple applications when it comes to dealing with my patients that are in orthodontic treatment, and even for just diagnosis of quiet conditions that I wasn't asked to look for. We'll take a full scan, and it's amazing what shows up in other parts of the mouth. And I've even found decay, relatively benign conditions that that were not seen in conventional radiography just because of the location on the tooth. I'm manipulating the volume reader and looking at things from different perspectives. It really is it's a game-changing piece of technology, and it goes hand in hand with a number of newer technologies that are arriving in our profession.